next turning to, that's okay, Department of Vermont Health Access. And our committee members will be hopefully here very shortly. Topper McFawn is with us this year, but he actually is at another meeting, so he may not join us. For those that are here, because we have a lot of new members, let's go through introductions and then we'll turn it over to you for introductions and we'll start. And I also want to say, we talked beforehand and we both have meetings at noon. The commissioner has to testify in appropriations. So we're going to try and stop about 10 of. And obviously with same thing with Department of Health, if we don't get through everything, this will not be the first time the commissioner will be here. So, so our Bobby, I'm going to start with you since you stopped chewing.
I was waiting.
I'm Bobby Thorley's Review from Caledonia Home Barnet, Highgate, Waterford.
Alan DeMar, Enosburg, Montgomery.
Pleasure to meet you.
Lori from Essex Junction.
Mari Cordes from Lincoln.
Stacey Rebecca representing Winooski.
Leslie Goldman, Wyndham 3, Rockingham, Westminster, and Brookline.
Yeah, Brett Bart Peterson, Rutland District 2, Clarendon, Wallingford, West Rutland, a piece of town.
Thank you. And I'm Andrea Delevrier, for the record, Commissioner for the Department of Vermont Health Access of the Agency of Human Services. It's a mouthful, but nice to see you all. Some familiar faces and some new faces. So
Yeah,
it's a pleasure to be here today. Thanks for having me.
absolutely. Joe, do you want to introduce yourself?
I'm Joe Andriano from Abington Rutland District. I live in Norwalk. Nice to meet you.
Great. All right, let's kick this off.
I have copies of the PowerPoint. Would anyone be interested in a paper copy?
It might be nice for a minute. Anyone else? Thank you.
Anyone else?
Yes, please.
Pass down.
Sometimes easier to follow along. Yep. Okay. Great. Okay. Well, thanks again for having me. Today is an overview of the department, which if you know anything about the Department of Vermont Health Access, there's a lot to unpack here. So we provided some high-level overview, understanding that we'll definitely have to revisit some of these topics in more detail as the session goes on. And I'm going to try to make sure I share the appropriate screen with you. I think it might have just booted me out of the meeting. Let's see, let's try it again.
Department.
Lovingly called Diva, yes.
Try not to make fun of.
Well, I make fun of it.
Oh, good.
So that's okay. It's an interesting acronym, but I actually like it.
It should be Deep Ha.
Deep Ha?
It should be Deep.
Okay, we'll go with that. All right. Sorry, I have to rejoin Claire.
Well, do you want to do an introduction real quick?
Oh, I just, Alyssa Black, Essex.
Nice to see you, Representative Black. I'm gonna try to scan. Got it.
So if I could just say it's better than Ova.
I completely agree. Thank you.
What's wrong with those?
Those are great.
Yeah.
Okay. All right.
We're just.
I'll just go presentation.
Yeah, exactly.
I love it. The diva. Okay. Just a little bit about the department's mission and values. The goal here is to improve Vermonters' health and well-being by providing them access to high-quality, cost-effective health care. We know that when people have health insurance, they're more able to access the care they need, including preventive care, which is super important. Vermont's uninsured rate is very low. We're very proud of that. It's according to the 2021 health insurance survey, it was 97% of folks are insured. Again, last time I checked, that was second in the nation. So
I was
You were
going to
gonna
ask that
ask?
question. Yeah, that's good.
yep, it's great. And, our core values, which we really do try to be transparent, have integrity, and provide adequate and high quality service all of the time.
So I forgot to ask, would you like questions during or at the end or?
I'm flexible, whatever works for.
Okay, we've been doing questions throughout. I'll just watch the time to make sure we get to, and if you know there's things we haven't gotten to yet that you want to cover, just say we're going to hold questions until then. So I think Joe has a question.
Yeah, I was just wondering, does that, the Vermont Household Health Insurance Survey also track those that are considered underinsured? And if so, what's the metric that's used to determine insured versus underinsured?
That is a Department of Health question.
Okay.
But I can make a note of that
Great,
and
thank you.
have some information. And it's also public as well.
So I can
you
find
might
this
be able to
report online?
find it.
Great, I'll just look it up.
Okay.
Thanks.
Sure thing.
I'll volunteer to do it for you. I'll get you something.
Oh, thank you.
Thanks, Ellen.
Thank you, Nolan. Okay, so just a little bit about what we do. Many of you may already know this, but good morning. Medicaid programs exist across all 6 departments in the Agency of Human Services. We, DEVA, play an integral role as we administrate the Medicaid program for the state, but we don't oversee other programs in other departments directly. Those are really the purview of those departments, with the state, the single state agency being housed in the central office, the secretary's office at the agency. So there's a relationship there that is sometimes confusing. But for example, mental health and substance use would be overseen by those individual departments. We really have 2 sides of the department that we talk about, and that is the Medicaid program as a whole, as well as the health insurance exchange, which is also called Vermont Health Connect. So that whereby folks can enroll in health insurance, qualified health plans, such as Blue Cross Blue Shield, Cigna, and Delta Dental, as well as Medicaid, you could do through that portal. But in addition, we also help Vermonters access Medicaid and we attempt to maintain a robust provider network to care for the people that need it. We pay providers for their services for Medicaid members, and we're always trying to innovate new ways to help provide high quality health care, but also, provide some sustainability for providers as they feel the increased pressures from the public health emergency and other factors. So, and we also strive to spend taxpayer dollars effectively by running an efficient department, which is a heavy lift. Medicaid's a big payer, where we have a big budget. It's $1 billion budget, which is about 1/3 of the agency's spend. Some priorities, we really have 3 key priorities that we're working on this year. Again, just to support our mission, which I've already shared, we want to improve overall health and well-being of Vermonters by offering them high quality, cost-effective health care. Value-based payments is an important goal for us. We are an innovator in the nation in terms of how we pay providers, and moving away from fee-for-service, where they are paid individually for the tests or procedure that they do, and move toward more value-based payments, which are linked to quality and less about volume. So that has been an effort that has been in progress for, I think, at least 5 or 6, maybe even 7 years now. And there's been some good progress, but it's a big change in how folks are paid. And there's a lot of methodologies that need to be developed. And then obviously the stakeholders need to align on that principle as well.
Yeah, and this question, Lori, is maybe as much to you as it is to you, Andrea. Since I've been here, all I've heard is about the value-based versus fee-for-service. What triggers it to happen? Okay, we're always working toward it, but who says, okay, we're going to do it this way? And who determines what that is? Or is that still out there, Lori, to be done?
So, I think it depends on what payer you talk with, and I'll let Andrea talk about Medicaid specific, but you have Medicaid, right?
Right.
You have Medicare, which is the federal government, and then you have commercial payers. And when the all-payer model was established and signed by the governor's office, Green Mountain Care Board, and Agency of Human Services, it was all voluntary participation by providers. And so a provider has never been told, you have to move to this. And so to
Okay.
me, that's a reason that one of the reasons it's been a slow uptick. The other reason it's been a slow uptick is we're talking about a really big boat that's going this way and we're trying this way.
Okay.
And it's a lot of players, it's a lot of money, it's patience, it's understanding the process. So, some people have said it hasn't worked. Some people have said it has. Then we had COVID, which, messes up all the data that we can use to analyze it. And so there's a lot that goes into that answer. I do think Medicaid is the best payer doing it. So I do want Andrea to touch on the question as well and how you've seen it work in your agency.
Yeah, thank you. I think you really said it very, very well. And thanks for the question. Medicaid specifically has, we have arrangements with the ACO. We have an arrangement with the ACO currently. We also have arrangements with providers and programs. So for example, the high-tech nursing program is one area where we have recently implemented more value-based payment approach, which does two things. There's been sort of a mixed review on as Madam Chair said, providers either are very interested in pursuing value-based payments, they're hesitant, or they're on the other side, which is absolutely not. So with high-tech nursing, it does two things for these folks. It offers providers predictable payments that they know they can count on, whereas fee-for-service is dependent upon volume of services that they provide. And so, and then, during, for example, the public health emergency, people weren't going to the doctor for quite some time. And this value-based payment program with high-tech nursing in particular, they had a number of hours that they didn't use because they didn't have enough providers to give the care. And so if that was a fee for service, they wouldn't have been able to bill for that. If it's value-based, they get a standard payment on schedule. And that's kind of how we have looked at it. We've had, again, some interest and have been successful with that, but it does
It's up to
involve
the
some risk.
provider to volunteer to do it at this point. Okay.
At this point, yes. And so next week, we'll have a presentation on the all-payer model to give some background. And then we'll also hear about what's happening with the negotiations right now with the federal government for if we do a next all-payer model. And so this will become a little bit more clear next.
Yes, there's a lot of discussions happening.
Leslie, did you have a question?
Yeah, I'm just curious, sort of the word value, like I worked in primary care for a long time. So if I'm involved in a value-based model, how does that work for someone like me? Like, why would I engage in it as opposed to not? Do I have to meet certain criteria with certain
There
diagnoses?
usually are
So could you
criteria.
talk about that a little bit, or maybe that's not for now?
I can talk a little bit at a high level. I am certainly not the subject matter expert.
Yeah.
But at a high level, there are measures that are really the quality measures tied to this payment approach. And so, for example, there's a timely filing requirement where providers need to submit claims within I think it's a 6-month period of time. And if they don't, they do have the risk of not being paid. So that might be a measure, for example, I'm just throwing this out there, but might be a measure where you would want to meet that in order to receive the value-based payment, where you're getting a total cost of care payment for your service for that individual. Again, I think there is risk, but for the right practice, it has worked well, or right program, I should say. Does that answer your question?
It does. It goes deeper, but not for now.
Okay.
Yeah.
Any other questions before we move on?
Okay. So another area of DEVA's focus is modernizing information technology, which is our never-ending battle. The state does have a number of disparate systems and with technology. Some of them are very antiquated, some of them are fairly new. And how do you make those parts and pieces fit together so that Vermonters can access, number one, enroll in health insurance when they want to and need to, access maybe their health information when it's helpful for them to do so. And then, how do we pay providers if we don't have adequate technology? So that is a focus for the department. It's a little unusual to think about health access and then on the back end have these big technology projects happening. But, we do work very closely with the Agency of Digital Services to try as best we can to kind of bring the technologies together so they're not siloed. And that's where we are right now. There's some initiatives going on. And then the third goal is really about performance improvement. We do have public-facing scorecards for many of the programs, and we make a lot of our policy decisions on some of the feedback we get from those. We're in the process of refreshing a number of them and maybe looking at different ways to track the work we do to ensure that we're moving in the right direction, but it's really to drive quality, improve customer service, and then be efficient about how we operate these accounts. So moving on to what we're doing. As we look ahead, there are many priorities that we have, but really these are the large buckets. There's a lot underneath each topic here. So I will try to keep it high level, knowing that there might be specific ones you want to talk more about. Open enrollment, which is where Vermonters go to Vermont Health Connect, enroll in qualified health plans, is happening right now. It is ending on the 15th.
Have to give it a watch.
Yeah, exactly. So it has been, this enrollment period has been interesting. We have a very large number of people in Vermont on Medicaid right now. And so our enrollment numbers for open enrollment have been down as compared to last year. We have about 2,600 new enrollees so far as of, I think that might have been 3 weeks ago. So that'll be closing soon, but it has been a significant effort on the part of the folks that do that work. Modernizing IT structure.
Do you want us to stop on each one or do you want to go through them all and then come back?
I'm happy to do whatever your preference is.
Okay, why don't we stop on each one?
Sure.
We'll just make sure we have time to
We can
get
do
to
that.
each one. Okay, Mari?
Is the modernizing IT?
Wait, we're going back to open enrollment. Sorry.
It is.
Oh, okay. It's connected to that. Okay.
Is because you mentioned it in another slide.
correct.
Is that is any of that focused on open enrollment?
It will be directly related to open enrollment improvements. Yes,
Speaking from personal
It is good.
experience.
it is good. It has been challenging, but it will be directly related to that, for sure.
So just a couple of questions on the open enrollment. Again, I just want to set the stage for anyone. Some of this is going to be repetitive with what we've heard, but I think it's good to hear it a couple of times. So you mentioned there's a lot of people on Medicaid, and that is probably due to the public emergency, correct? So we haven't done any redeterminations, and so people have stayed on Medicaid through the public emergency. And I believe that ends April 1st.
Yes, and that's its own individual bucket.
Okay, so we'll get to that. Great. And then of the 2,600, and I don't know if you know this, bless you, is that it could be a qualified health plan or Medicaid or Dr. Dinosaur or all the other options?
I believe the 2,600 is specifically qualified health plan.
Qualified health plans.
Health plans, yeah.
Great, thank you. Any other questions? Great.
Okay, so modernizing IT infrastructure, again, this is an area that'll touch a lot of not only just DIVA programs, but across the agency. So we're looking at really improving the integration of those different disparate technologies. Advancing value-based payments, obviously, we talked a little bit about that. I don't want to spend too much more time on it, but I'm happy to. Oh, sorry. Were there any other questions on infrastructure?
Okay.
And value-based payments. Nothing new to share there other than it's a top priority. And it is something that we have many projects in flight, not only within the department, but across the agency. I'm working on these enhancements. Any questions there? Global commitment to health. I know that you are going to get another presentation with Ashley, the DEBA Policy Director, and Nolan, I believe, is in that as well. So I won't spend much time on that, but we did land in a very favorable position with the new 1115 waiver, which is the framework that guides our program in Vermont. And that was effective in July, and it was for 5.5 years. So that was a significant accomplishment. We were able to move some pretty important negotiations forward to benefit the state of Vermont. So I'll let Ashley and Nolan dig really deep on that unless there are other questions. Looking at staff, workforce recruitment and retention is, I think, a problem and a stretch and a struggle for everyone. We've been really fortunate at DEBA to be able to recruit talented folks, but we still have challenges. And particularly related to the next one, which is unwinding, the staffing continues to be a concern. So unless there are questions about workforce recruitment, I'll move.
I think you can roll
unwind.
the unwinding, yeah.
So related to the public emergency, the federal law prohibited disenrolling Medicaid members throughout the time since March of 2020. And therefore, we've seen growth in the Medicaid program, consistent growth throughout the past 2.5 years. We're not seeing people disenroll. And the only way that we could disenroll them is if they asked us, and they're not asking.
I want to go back one square, could I?
Sure.
Staff workforce, just wondering, do your folks, some of them or all of them work from home? Or are they at a desk somewhere?
We have right now, they don't all work from home. It's a hybrid environment. So we do both.
Some do, some don't.
They all are in the office.
They all are in the office at some point.
But it is a hybrid situation, so not the 5 days a week.
Taking the pandemic out of it, can these folks work from home with technology we have?
We've been really fortunate and successful to have, the answer is yes, with some criteria.
Yeah.
You have to have effective broadband, and you have to have a laptop that's working, and a phone, and all of those
Okay, but
sources. But
assuming
the work
that,
part,
yeah, assuming that's there, that there's an internet connection, that you got a laptop.
yeah, yeah. So it is possible, I think that where I land on it personally is that there are some really key benefits to having in-person contact for teams. One of those is creative thinking. It's really great creative thinking to have folks in a room and to be able to share ideas.
I hear you.
And also for onboarding. So when new people join the department, it's really great to be able to have them meet and connect with people, because the virtual connection is not generally as strong in the beginning.
Yep.
So there are some really important reasons to continue to have, and we do have those regular in-person meetings. So that's, but the short answer is yes, but.
Yeah, gotcha. Thank you.
Welcome. Okay, so unwinding. So the federal law, again, prohibited us from disenrolling Medicaid members. Right now, we have an additional 36,700 and, I might get that wrong, but it's 754, I think, members than we had pre-pandemic enrolled in Medicaid. Puts a lot of pressure on the system and the state. So where we are today is that the omnibus bill that was recently passed in Congress did have a provision where they were uncoupling the requirement for continuous health care coverage with the end of the public health emergency. So previous to the omnibus bill, it was combined. You could not disenroll anyone or redetermine their eligibility until the end of the public health emergency. That has changed, and it is April that we will begin to, they call it unwind. You'll hear it all the time. It's an interesting term, but basically many folks may not be financially eligible for Medicaid any longer. And so we will begin to use some data relevant to their financial status or outreach directly to Medicaid members to redetermine all 206 or 208,000 Vermonters in the next 12 months, 12 to 14 months.
Leslie and then Art.
I'm just curious to know who gets up first, because that would be harder than if you had a whole year without.
You know what, I think what I'm gonna do is let's let her finish, because
Sure.
some of these questions might get answered, and then, so keep on, write them down if you need to. Let's get through
They're
this
great
part.
questions. Yeah. So what we try to do is prioritize some groups. For example, a group that we would prioritize would be folks that we know don't qualify, but potentially would qualify for a health plan, a commercial health plan, and then link them to that. And then we would deprioritize other groups. For example, an individual who is expected to have a child during this unwind period, we would, because of the expansion of the postpartum coverage, last session, you may remember, all of you may remember that, or most of you, that extension has happened, and it will be an additional 12 months, I believe, of coverage. So we would not want to prioritize an individual not having health insurance for that period of time when they could be eligible, if that makes sense. So we have a plan, an unwind plan. There's a lot of information available on the website, and I'm happy to provide that link when we're done, for you to go look at that. We have not updated the April date yet, but we're in the process of doing that in terms of unwinding. Does that answer your?
Yeah, the thing, if I may, it makes me think about your IT and how that intersects, but it works. I mean, you feel
Well,
confident.
so the data pieces are there already, in terms of financial information or whatever is needed to redetermine. And then the direct outreach will happen either, and there are lots of methods. One of them is text messaging, which is a new option for folks, and it seems to be working really well. We've piloted it in a number of areas to say, please contact us, please make sure we have your updated address and phone number, and, reaching out to people via various methods. Postcards in the mail is another one. So there are lots of touch points, and we're hopeful that they will get another crack at it. If they don't respond the first time, we'll do another outreach and hopefully get a response then, because we don't want people to be uninsured, obviously.
Yeah.
Art? You good? I thought you had a question, no?
No.
Okay. I have a couple, unless you want to keep going with this.
Happy to answer if I can.
So how long do you think the unwinding will be, and do you have enough staff?
Those are great questions. So we have 14 months, according to CMS guidelines, to do the unwinding. We think it'll take us at least that. It's a big, big challenge. In terms of staffing, we have been planning for this for a while. Adding positions is a difficult thing in terms of workforce. We are really looking at an all hands on deck approach at this point and figuring out the areas where we have gaps. We have call center folks that we could potentially expand on, but we're, I would say, going to be stretched really thin for a really long time, and that's one of my biggest concerns as a team.
Yeah. Because you've already been stretched, really.
2.5 years, yeah. It's been, I will say that the folks in the department, and I think across the agency, have been so very dedicated, but people are tired.
Absolutely.
As is everyone else.
I have a point and a question. We've been hearing from some advocates, something like in April, Vermont government is going to suddenly just cut off a bunch of people's Medicaid. And
That's scary, right?
that's a scary thought, and it's not happening
That's
that
not
way.
true.
Yeah. So that was the statement. Thank you for confirming that. And when I've been thinking about unwinding, the unwinding part, I've been thinking about patients or the Medicaid recipients. But what about providers, including pharmacies, and what happens to claims that are in process and payments to providers and pharmacies?
Yeah, it's a great question. You know, we are not intending to, do you mean if a person is not eligible and a provider submitted a claim after that?
Yes,
It would not
if
be
a person
paid?
is no longer eligible, then what happens to claims you've already paid during the current period
Or not paid.
Or not paid.
or not?
I think the not pay would be a bigger issue. And I'm gonna follow up on that piece because I don't know the time frame. There is a run out period with claims where you have a little bit of additional time. But let me find out because I don't want to give you a wrong answer.
Okay, thank you.
Art and then Joe.
Yeah, just to follow up on what Mari just said. Because any of us might get inquiries from constituents. In April it ends, but I mean, do you see this happening alphabetically somehow so that, I mean, I assume you're not gonna cut off Medicaid without some fallback for the individual. Is that how that's going? I'm just trying to visualize, and pardon me if you've already mentioned it.
No worries at all.
I just want to be able to assure and, tell someone that
Yeah.
you're going to have coverage somewhere.
We will do, so what I can say is
If you don't
It's
know,
the
tell me.
beginning. in April, it's really the beginning
Yeah.
of the end. We are doing and will do everything we can to make sure that people have access to health plans.
Okay.
We have lots of stakeholder engagement support, including Vermont Legal Aid, to help
Yeah.
with the process.
Okay.
But I will say that one of the significant benefits that is in place that was not in place as of maybe even 8 months ago are the subsidies available for qualified health plans, which now are in effect for 3 more years. That was not accessible before.
Okay.
And that makes plans, qualified health plans, more affordable. So I feel more optimistic than ever that, we're going to have fewer places where people are going to fall off without any health insurance at all. I hope that answers.
Yeah, no, I understand the complexity, and I mean, that's kind of what I'm looking for,
And you asked about alphabetical. It's more about groups of people and where they are in their life circumstance right now
yeah,
that we're trying to make sure we're thoughtful about.
okay.
And getting the guidance from CMS is also one of the.
So everybody's not going to hear at once.
Correct.
Okay.
Absolutely correct. And it will be a month by month number of people that are redetermined, not to exceed, I think it's 7,800 people a month.
Yeah.
So it's going to be a slow unwind, even though it may not feel that way for some
Just
people.
a suggestion,
Sure.
and this has happened in other things. We tend to get announcements from departments saying they're going to do this that involves the public.
Yes.
It'd almost be good for us to maybe get something from you, and then we can put it on Front Porch Forum. I put them on Front Porch Forum where I live and say, look, this is happening.
Sure.
And so that folks that are involved might have a warning ahead.
Sure. Yeah, I appreciate
Just a
that input. I'll definitely take that back. Because we will probably put something out. We're just not exactly sure what that looks like.
Right.
Because it's not a great press
I can
release
imagine.
topic.
I can imagine.
And I would suggest, one thing, I think that's a great question, Art. We're always looking where we can help, spread the word.
Thank you.
And I think one of the things we can do is say, if we're talking to constituents, if you've been contacted by the department, get back to them, right?
Thank you.
You need to have correct contact information in order to be able to help someone. And the subsidy is really great to have that, to be able to move them to a qualified health plan that will provide some support. Will some end up not having insurance?
Yeah.
That's a possibility. And it also could be their choice. So that's, something else we have to remember. But we can play a part in getting the word out. Joe and then Leslie.
That answered my question.
Okay. Leslie, and
I
then.
was just wondering if there was a hotline or something along that we can use to say, here, call here.
Yes, the website, I'll point you to the website
Okay.
with the contact, unwind information for sure. Yes, thank you.
Not that I feel like we're all telling her how to do her job.
know.
But I would also encourage the department to engage with the provider community,
Yes,
to let them know this is coming, because I can tell you they don't know.
yes,
And that is often
the
the
problem.
place of contact where they are the first to know that somebody is no longer eligible.
Yes, and I appreciate that. We just had a meeting about that
Okay.
last week, about how do we get the communication out to providers in a meaningful way that's not necessarily in a banner that they have to log into the
Your
website.
banner page.
Definitely on it.
And then just one last question. So, although we're not in an open enrollment through this process, you will, let's say the first people are contacted in April or May, you will be able to move them to a qualified health plan mid-year.
Yes,
Okay.
yes. There's also a special enrollment, a continuous enrollment period for folks that would financially qualify as well, which doesn't have specific dates where you can enroll or not. So those two avenues are really important. I'm trying to think I wanted to comment on something else you said, but
Any other questions on this topic or anything else you?
nope, I don't think so. Again, it's communication is important.
I think I heard you say workforce was also related to the unwinding. Is that because
Yes.
you're gonna need to staff up
Correct.
for the,
Right, we need to reallocate workloads for existing people and ensure that, the other work that is the responsibility of the department doesn't get dropped. It's a dance.
yeah, so it's not just redeterminations, it's also Vermont Health Connect might have
Right,
more work, more applications.
right, exactly. And, on the other side of that, we have a bunch of people that they love this work and they're gonna stick around to do the work, which is really great. But on the other side of that, it's also, we need to be able to balance it as best we can with the other things that they have going on and the other things that we need to do as agency level priorities. So it is tricky for sure.
And if you don't mind, I'm going to turn to Mike Fisher of the Healthcare Advocate is here. And if you don't mind me asking you a question, your call numbers are going to go up probably. So how are you anticipating that working for your organization?
Mike Fisher, Healthcare Advocate. Our numbers are actually down a touch currently because while there's lots of people who are applying for Medicaid now, we are not helping people through the redetermination process. So we are expecting it to go up some, and yes, we are bracing ourselves for
Yeah.
that. We scaled back our ability to respond to some things that are less urgent, like billing issues, which are very urgent for people, but they are not urgent access to care issues. At times when we're overwhelmed with more immediate needs. And then if I might, I want to make another point, it's not just the 37,000 additional people who we think may be on Medicaid, it's the entire Medicaid population. I don't have the number off the top of my head.
About 208,000.
208,000
The whole
that have not been going through redetermination and will soon start to go through redetermination again.
Hence the 12 to 14 month runway. Yeah.
It's a lot. Yeah. Well, keep us posted on the efforts.
Here.
We're grateful. We are extremely grateful to everyone working in both organizations that will have to work through this.
Thank you, and thanks for your support, because I'm sure that we will definitely leverage your expertise in getting the word out for responding to us when we reach out. And then the last bucket is really just provider sustainability. There are lots of pressures on providers right now, both from workforce challenges to increased cost for supplies to inflation. And so we're doing what we can and have done what we have been able to do in terms of providing sort of financial relief, whether that's emergency relief funding through COVID initiatives or by, looking at ways that we could improve the way we pay them, the value-based payment approach, so it is we are deeply steeped in all of those efforts, and it does touch every department in the agency, really. So that's it's a short list of things that we have to do. But any questions before I move on?
I just have one, which you may not go into, but I'm curious, and this might be something we talk about later. One of my goals is to talk about telehealth again this session. And I've been hearing that with the end of the public emergency, that may change some of the telehealth policies through DIVA. Can you elaborate on that now, or is it something you want to come back to?
A little bit. I think in terms of the telehealth conversation, we're not discontinuing telehealth or audio only. Those are here to stay, and reimbursement for audio only may change as a result of the end of the public health emergency, as it wasn't an option prior to the public health emergency. So we're discussing that. But in terms of the offering, nothing changes.
I appreciate that. When you talk about audio only, and it wasn't an option before.
Parity to,
right. And my question is, it wasn't an option before because the Medicaid plan here in Vermont chose not to offer it, or because there's some rule connected with the federal guideline?
It's not a federal guideline. I think it was a Vermont-based decision.
Okay. So we'll bring that up again. I would love to get some more information on that. Leslie?
Yeah, I'd like to know how we get there to, what's the process to at least discuss it and have parity?
We'll be having testimony on it.
That's great. Thank you.
Perfect.
Great, thank you.
Sure. So here, just a short list of topics we could help with. We've discussed all of them, actually. So you may hear Green Mountain Care out in your travels, and that really means Medicaid. One of the things that we're doing is a research project through the Vermont Certified Public Managers Program to understand brand awareness. There's a bit of confusion. Mm-hmm. I know I was confused. People don't know necessarily that Green Mountain Care is Medicaid and vice versa. What is Vermont Health Connect? Is it its own company? And no, it's Department of Vermont Health Access. So we're looking at some of the ways that we could potentially improve the communication between brands and align our brands better. But it's not a brand change or anything like that. It's just a research project to figure out, are people comfortable with this? What's their perception? So that might be something you hear about out there. And then, like I said, I won't read the list, but the impacts of the public health emergency are the ones that people think about the most these days.
Yep. Great. Any questions? Okay.
I have questions that I don't expect you to answer today, but I would like to ask for the future, just to plant the seeds of and maybe they're just questions like committee,
mm-hmm.
which is in terms of information technology systems and VHI, I think that's how we say it, right? The Vermont Health
Information.
Yeah, exactly. Yeah. What would be the benefits and impact on cost of moving towards a unified medical record system for the state? Because I know separate providers are paying a lot of money for different services, and it's not very well coordinated. And then there's the issue of it opting into VHI, and just what might be the benefit of adopting a statewide medical record system that providers are just given access to in the state funds, so that takes cost off of providers and saves the system money. And how might we be creative in using waivers to explore taking steps towards the original vision of Act 48, whether that be for universal primary care or some other mechanism, and just what are the options on the table? When we're negotiating around this global commitment and Medicaid stuff, what are just various?
What can we do?
And just where the administration's at with exploring how to use waivers creatively to increase access and reduce costs for people.
Yeah, those are great questions. I think that to the first question, I would say, I just want to clarify, do you mean electronic medical records, or do you mean access to medical information?
I would say a unified electronic medical record system.
Okay. The VHI is more access. And the EMR, electronic medical records, is more input your data here for your patient.
Yeah.
So those are two different things, but I understand where you're going there.
Yeah, and it's confusing, I think, for a lot of people. I'm sorry, the fibers of the mask are starting to break down. It's disgusting. So gross. I'm so over it. But it is confusing, I think, even for providers sometimes, like with what we have our own sort of silo, our own little information storehouse, but which providers are sharing what information to VHI and which providers are accessing it. And there's sort of this complex infrastructure of information that's not well coordinated from my perspective. I don't want to but I'm curious to learn more about where we're at coordinating that. And I mean, would there be a benefit? I think there was talk at one point about using the VA's medical record system universally. I don't know where I heard that in one of our committee. You might remember it too,
Yeah.
But I don't know. I'd like to look at that more.
And I think what would be helpful is for Vital to come in.
Yes, yeah.
So Vital is Vermont Information Technology Leaders.
Good job. Yeah.
It's a long time ago that I was. And so providers have their own, hospitals have their own electronic medical records that feed into Vital, which is essential. So, Bobby, if you're where you are going to your hospital, but then you come skiing up at JP and get injured, I hope that doesn't happen. They would be able to access your medical records from your care where you live to ensure that, they are doing the best they can. And that's come a long way. And so I think it would be beneficial to have them come in and give an overview as well, and then talk about VHI and all the data. Yeah.
Perfect. Great. And then to your second question, in terms of waiver flexibilities, Rep. Sheena, I think that Ashley could potentially answer some of those questions this afternoon in terms of flexibilities that we have with the new waiver. So she's really the expert in that
So
area.
maybe I can think more about the questions and others, and we can come prepared this afternoon. Okay.
Yeah,
Thank
perfect.
you.
You're very welcome. Okay, and then just a little bit about, sorry.
Go ahead.
No, I just wanted to can I ask you a question?
Yeah.
I just wanted to take an opportunity since you were here, and it's a program that I'm personally invested in, I feel like, the immigrant health insurance plan.
Sure.
So it's been in effect for, I think, July of this past year. I know, based on the website, you have the IHIP application in a Spanish version.
Yes.
But you still don't have the other application, which is the standard Medicaid application, which is where somebody would apply for emergency Medicaid.
Correct.
That's still not in Spanish.
Correct.
Are we working on getting a Spanish version of that?
We are. We are working on the timeline as well. Just to kind of give you a little bit of the landscape of where we are today. Since July, so the Immigrant Health Insurance Plan, a program, is everyone here familiar with that?
We heard about it once, so let's do another quick overview.
Essentially, it's coverage, Dr. Dinosaur-like coverage for individuals, pregnant women, or pregnant individuals with children to be covered. It is a state plan, state-funded plan, and it has been in effect since July of 2022. So where we are today is there have been 59 enrollees in the program. 3 of them, I believe, needed Spanish translation. And so, as we kind of look at the landscape of where this program may be going, we think that having a Spanish translation for the Medicaid application, not just for IHIP, is important, but it's not a CMS requirement. So we think it's the right thing to do. And we're moving toward that.
If it's an emergency situation, though, that would allow us to receive federal dollars for that. So, wouldn't we want to get them under the emergency program if we can possibly do that so that we can draw down federal dollars for it?
And I'm going to go back to the team and see where we're at with the timeline piece of it. But I think right now, if someone needed in an emergent situation, my understanding is that they would have access to a translator. And that's what I was told this morning anyway. That it is accessible to them via translator, but it's not ideal. If they can go in and do it on their own, they should be able to do that.
It'd be helpful. So once you check back with your staff, if you can just send a note to Claire to send out to all of us, that would be really helpful.
Sure thing.
Status of that.
Thanks for the question. Okay, so,
Sorry, Tyler.
And maybe I misheard you. Did you say that the people that were eligible for this were pregnant women with children
and their children, yes.
and their children? Okay. Okay, that's good.
But they don't have to be, there are other children too.
Regardless of immigration
Yeah,
status,
I mean,
yes.
it's not only children or pregnant women, it's all children of all immigrants in that group, right? Am I not understanding?
Yes,
Right,
correct.
yes, it's
Yes.
beyond
I can see
children.
how you could misunderstand that.
Yeah, sorry.
Sorry about that.
No.
Daisy?
I apologize for the kind of weedy question, but I believe it was in the Building Safer Communities Act. There was new authority, I think, given by CMS to do some, and I don't quite understand it, but do some adjustment of risk modeling that would basically allow for better monitoring of outcomes with regard to social determinants of health. So factoring that in as a risk factor rather than just simple diagnosis codes. So I wonder if, I don't know if Addie or Alicia is the one to ask about that, or if you can speak to whether you all are looking to that.
Capturing social determinants. I think the key first step would be, are we capturing and what do we need to do to capture? It is one of the things that is on our list of things that we need to do. And it is important, but it's also many times voluntary. And if someone is not comfortable providing that information, we wouldn't be able to capture it. So what we're looking at right now is technologies that we would need to enhance what we currently have to improve that. But risk modeling is like the deeper in the weeds conversation.
But isn't AHS standing up community profiles?
I'm not sure where that is right now. That was definitely one of the topics that was on the list, but since I'm not in the secretary's office anymore, I've lost track of it.
I forget.
But happy to follow up with you.
Yeah.
Okay, great. Okay, great. Just in closing go ahead.
Well, I thought that was really interesting to me, so if you could follow up with all of us, that'd be wonderful. Sure. I'm just saying, rather than one-on-one.
In terms of
so the question of capturing social determinants of health for determinations, that's what I understood your question to be. Am I getting that?
I can articulate it in an email to you, so it's clear
Okay.
to your staff.
That would
Follow up.
be helpful.
Yep.
I was
I'd be
just
happy
hoping
to
we
do
could
that.
all get the response too.
Yeah, sure. Share it with you.
Sure thing. So just the Commissioner's Office team is comprised of myself. Addie Strumolo she's mostly on the enrollment and eligibility side. Sandy Hoffman is another deputy commissioner who's on the clinical side of things. Alicia Cooper is our director of managed care operations, and she does a lot of the work with rate methodologies, value-based payments. Her team does a lot of that work. And then Ginger Irish is our legislative liaison. You may have interacted with Ginger already. Great. We're really pleased to have her as a newer member of our team. And certainly our emails are there if there's anything we can do.
Any last questions?
There's a lot.
Yeah.
Maybe we just touched the surface, but this is a really good overview. Daisy?
Can you pronounce your last name for us one more time?
Oh, sure. It's de la Briere. It's actually 3 words. Yeah.
De la Briere?
De la Briere.
De la Briere.
There's a lot of in my area,
Where you live?
near St. Johnsbury.
Mm-hmm. Yes, big family,
Named Ethan, your nephews.
Quebecois?
likely.
Quebecois, the last name?
It is,
Okay.
yeah.
Beautiful last name.
Thank you. It's many, many letters too long. I appreciate the opportunity to be with you today. So thank you very much for having me. And we will follow up. I have fortunate to have people taking notes, so I didn't have to.
Great.
Thank you.
Thank you.
Thank you very much.
God, she's got a great memory. I'm impressed.
I just disclosed my secret.
So we are breaking until 1, potentially 1:15, so check your email. I will have Claire send in a note, but then this afternoon, we will be going over the new Medicaid waiver titled Global Commitment. So that'll